I'd like to share about a patient who I met during my psychiatry clerkship, who I'll refer to as Stephen as a pseudonym. Stephen is 51 years old and arrives to our emergency department accompanied by his wife, who's both frantic for help. As our interview unfolds, I discover that he's profoundly depressed with active suicidal ideation and a plan. Over the past few months, he's been suffering from a cycle in which he's spun from a depressed vegetative state up into a hyper-aroused manic frenzy, only to crash back down over and over again. His dedicated wife and 3 kids are suffering dearly as well. He is visibly embarrassed as he tells me how he finds himself consumed with paranoid thoughts of being abandoned by his family, causing him to lash angrily out at them, blocking the door, trapping them inside with himself and his madness. Somehow, though, his current medication list does not include a mood stabilizer, and I'm further shocked to learn that this is actually his 2nd trip to the ED in less than 3 weeks. On his first visit to a psychiatric ED at a neighboring hospital, he was unwillingly transferred to a different hospital since the first didn't accept his health insurance. After a week at that second hospital, his wife helped him sign out due to complaints of lack of care, overcrowded facilities, where he was feeling worse instead of better. After a week at home and one $300 out-of-pocket visit to an outpatient psychiatrist, because again, his insurance didn't cover outpatient mental health, he deteriorated further. The couple desperately decided to give the ED another try, this time ending up at the hospital where I was working. After hearing the patient's story, the attending physician and I decided that a psychiatric admission was well warranted, and the couple agreed, begging me only not to send him back to the same hospital where he was hospitalized previously. What I'll tell you next offers a tiny glimpse into what it's like to try to practice patient-centered medicine in a system that allows for the existence of insurance companies who are more concerned with their bottom line than a patient's well-being. As a medical student, I was actually instructed by the attending physician I was working with that when I got on the phone, to be sure to describe the patient's condition as especially dire when I presented his case, because this particular insurance company has a reputation among physicians to try everything they can to get out of paying for an inpatient admission. I did not lie about the details of the case. The patient very much warranted admission. He was actively suicidal and had a plan. But I did spend hours on multiple separate phone calls as our clinical judgment for his admission was cross-examined and disputed by the insurance reviewer, who clearly had other interests at heart than Stephen's health. I did eventually win the battle with the reviewer and receive my prize, a 5-digit authorization number scrawled on my notepad. Next, I got on the phone with the hospital that had already agreed to his case and was supposedly holding a bed for him. As I proudly presented my hard-earned authorization number, I was told that there's a problem. It turns out that in the meantime, their billing staff did some more digging, and they had found out that this hospital had actually rejected the patient 3 weeks earlier when he had presented with the same case. He was rejected because they, quote, couldn't figure out why he had active insurance since he lost his job months prior. They denied him admission on the grounds that there was a chance that during the psychiatric admission, the insurance company might pull his coverage and they would lose money. I was told that I, the student, had to go find out why the patient still had active coverage. And if I could provide them with sufficiently comforting explanation that ensured they'd get their payment, he would be admitted to their facility. Although I was livid, I knew that I had to play the game the billing department was demanding of me if Stephen and his family were going to have the chance to heal. Stephen told me that the manager from the building where he was a doorman for 20 years had been paying his insurance premium in order to help keep the family afloat. As the icing on the cake, when I called the hospital back to present this information, they further demanded the manager's phone number. They couldn't be sure that the manager was actually paying the insurance and that they would ultimately get their money unless they spoke to him themselves. Although I, again, ultimately was able to deliver this information and Stephen was successfully transferred to receive his inpatient care, I felt little reassurance that he would be able to successfully fight against the myriad of interests working against his quest for health. Bipolar disorder carries a fairly good prognosis if properly managed, but the misalignment of incentives in our healthcare system has all but put it out of reach for Stephen and thousands of people like him around our state. The New York Health Bill would be a significant step forward to mitigate many of the factors working to systematically deny Stephen the access to care he needs. First, with the implementation of universal health coverage with no out-of-pocket costs, Stephen would be able to have regular visits with an outpatient psychiatrist, maintain on his bipolar treatment, and the manic depressive episodes that cost his family so much emotionally and financially would have been prevented. Second, Stephen's health insurance would have been guaranteed just by being a resident of our state, instead of being tied to his employment status. Now, Stephen was very lucky. He had a compassionate manager who continued to pay his premium, but that's rare. All too often, it's very common for people who can't work because they're sick to lose their employer-provided health insurance right when they need it the most. Finally, the New York Health Bill would end narrow networks so that hospitals would never have to force patients like Stephen to go to a hospital that is not good for them to transfer his care just because they don't accept his insurance. The benefits of a single-payer system like the New York Health Act are very clear. And also its impact on our state economy and improvement of our overall healthcare system are equally as impressive. Stephen's manager could invest the money that he's been using to pay his former employees' premium into building improvements instead. For providers, the New York Health Bill would establish a coherent system in which physicians, residents, and medical students like myself can spend our time on patient care instead of being bogged down by fighting with insurance companies and spending hours of our time dealing with complex billing. Our patients would no longer be forced to choose between paying a high copay for their medicine or their rent that month, and we would have the luxury of practicing good medicine without having to take into account our patients' ability to pay.